just start the meeting, if that's okay. Right, so welcome everyone to Kingston CCG governing body meeting today. There's a script that I do have to read out. So in relation to questions from members of the public, CCG is committed to openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. Although the meeting is held in public, it is not a public meeting. This means that there is no opportunity for the public to ask questions apart from that offered at the chair's discretion. There is a specific slot at the end of the agenda as well. The governing body meeting is also being video recorded as part of the commitment to make information as accessible as possible. The video will be put onto the website within a few days of the meeting, and the CCG does not allow any other recording of the governing body unless agreed by the chair prior to the meeting. The CCG has a protocol setting out how it will conduct its meetings, and this is available on the website. All right. So we've got apologies today from Phil Moore and Attingol. Any other apologies? Catherine Yates and Nadine Name. Yeah.
Liz Mirabel.
And Liz. Okay, Liz Mirabel. Okay, thank you. Can I just ask people just to put their mobile phones on silent or switch them off if possible? And are there any declarations of interest which aren't already declared pertaining to items on the agenda? No? Okay. So if we can come to the minutes of the previous meeting back in July. I'm not going to go page by page, but as matters of accuracy, are there any issues that members wish to bring up as regards matters of accuracy? No? Okay, so if we can sign them off as an accurate record. Coming to the action log, we've got one which is around the local health and care plan, which has been brought back in January. There are two other elements, and I don't know whether we've got someone to be able to feed back on Julia's behalf around the CQC SEND inspection and also the end-of-life care strategy, because I'm not sure whether these have been actioned or not. No?
Yeah, we'll follow it up. I've got an update on the SEND on my managing director's report, so that might cover some of that elements, but we'll follow it up for the rest of it.
Okay, so if we can follow up about the CQC with Julia when she's back. Thank you. Okay, so are there any questions from members of the public pertaining to items on the agenda that you want to bring up at this time? No? Okay. So items that were taken in private on the 2nd of July were pertaining to the relocation of the Cedars unit, and it was an update in part 2 on the 2nd of July around the community beds. I'm just going to go through a very brief update around the CCG Chair's report. So essentially, there's been an awful lot of information and also feedback on local discussions around the proposed South West London merger, which I know that Sarah is going to bring up in her report. And also we've had discussions with the local pharmaceutical committee as well as the LMC and our RBK stakeholders around the proposed merger. We've also been discussing with the the primary care network clinical directors around the opportunity to employ staff going forward, and particularly around the MSK first contact practitioners. And we're going to be having meetings with the clinical directors next month. Kingston Hospital locally, we've been having discussions around planned care and radiology IT, which are progressing very well. At a London level, the London Chairs meeting next week is going to be having a discussion with David Sloman on specific aspects around clinical leadership and also primary care network support. And at a national level, the NHS Commissioning Committee Board was also talking about shifting the commissioning landscape, talking about CCG mergers, and also the offer of support to primary care networks, and also to the transition of ICSs and STPs. On a personal note, I'm taking the remit on the clinical lead for the SEND, because at the moment, because obviously Pete Smith has medically retired, and we are seeking to look for Pete's replacement on the governing body just for the next 5 months at least. Okay, so that's my very brief update. Sarah.
I don't have anything specific to add apart from the merger and long-term plan discussions that we're having on the agenda.
Okay, great. Thank you. Tonya.
Thank you, Chair. A few items to update the members on this month. Primary care networks, pleased to say that we have successfully established 5 primary care networks in Kingston, and they're all now operational and really absolutely starting to take shape and start to work on the areas of priority that have been identified for this year, which is, they're taking on responsibility for delivering extended hours provision, and they've started to work to recruit the social prescriber and the clinical pharmacist roles, which they've been funded for this year. One of the other areas that they're focused on is actually their organisational maturity. They have completed a self-assessment that will support their development needs over the next 5 years. The focus of those development needs are really around governance, how they establish their own internal governance, and also clinical leadership. So really pleased that they're up and running and that they're engaging with the CCG, and we look forward to working with the PCNs going forward. And then moving on, as part of the Modern Slavery Act 2015, CCG is obliged to publish an annual statement setting out the steps they are taking to prevent modern slavery in their business and their supply chains. Just for the members to note that our statement has been published on our website, and there's a link in the report if members want to review that statement. And then moving on to SEND, as Naz has mentioned, SEND is a top priority for the CCG this year on the back of the written statement of action. So we've taken forward some action since we last met. I'm pleased to say we now have our full-time designated clinical officer in post. They began on the 9th of September, and that role is really around how we ensure better oversight and quality of the health services input into EHCPs, and developing an audit programme around the timeliness and quality of health advice provided for EHCPs. So the appointment of a full-time designated clinical officer for Kingston and Richmond is seen as a real step forward in that area. We also have started work on the therapies review. We've held some consultation engagement events in July and August, and we are starting the next steps to finalise the remodelling of therapy services and to produce a business case for consideration by the CCG and Council in October. We've also started to co-design under 5's neurodevelopment pathway to reduce waiting times, and we've had a workshop with carers, parents and providers. How do we develop our service for the under 5s? And again, we will have a follow-up workshop in October, and the aim to have a nice compliant pathway in place by January 2020. So also what we've around the SEND agenda, we have now moving towards a more productive and positive relationship between ourselves as statutory partners in the LA and parents and carers, and we have established the parents panels to positively engage with parents and carers and to jointly develop a local model for the effective engagement and co-production. And finally, we have developed a high-level joined-up SEND performance dashboard that will give oversight and monitoring tool on 8 multi-agency outcome areas. So I think that will also help us focus the SEND's transformation board's focus on delivering improvements for SEND. That was all I was going to say about SEND, and we'll follow up the action. And then finally, I just wanted to talk about other bit around children and young people was our mental health support in schools. So we, as you would have heard before, we have been successful twice now in trailblazing funding for improving or developing a whole school approach to mental health in schools. And we were lucky enough to get that Wave 2 focus more on Kingston. So Kingston will have additional funding for a bigger team to put a place across the schools and a new team working across further education colleges. And finally, just a reminder to the members that our AGM will be held on Tuesday the 17th of September, 5:30 to 7:30 at the Queen Anne Street at Guildhall, and everyone's welcome. So, but happy to take any questions.
Great, thank you. Any comments or questions around Tonya's report from members? Yes, Rob.
It's a mixture of primary and secondary.
Okay, thank you. Any other comments or questions for Tonya? All right, so if we can come to the Audit Committee Chair's report. Paul?
Yep, thank you, Chair. Can be fairly brief. There was no local Kingston CCG Audit Committee since the last governing body meeting. However, we did have the South West London Audit Committees in common at the end of June, and no sort of issues really to bring to the governing body meeting. It was a fairly procedural discussion around the internal audit plan going forward, local counter fraud plan going forward. And really, I think, I can't remember Neil or James were there, still discussing how governance will work with audit committees going forward in the, the merger proposal. But other than that, Chair, that was pretty much it.
Thank you, Paul. Any questions for Paul around the updates? No? Okay, so Sarah, do you want us to come to the long-term plan?
So at South West London level, we are required to produce a plan that is a reflection of the national long-term plan. It is a system-wide plan where we incorporate the views of our providers, commissioners and local authorities within South West London. And we have to put in a draft by the end of the September, and then the formal final documentation will go in the public domain and be published on the 15th of November, I think is the actual date. So the approach that we're taking in South West London to this plan is, and you will remember, we refreshed our STP plan last year, and we talked about developing our local health and care plans, and we talked earlier that in January you're going to get the Kingston one back here again. Well, we are going to be building our South West London plan on the local health and care plan. So the development of the South West London long-term plan will be built on the 6 plans from each of the boroughs across South West London. And if I take you to page 2 of the report, you will see that there will be key chapters to our plan. The first being the local borough plans, which will be the building blocks. Then we have worked with the Clinical Senate, which is the South West London, where we bring together all the clinicians across South West London to look at priorities, and we'll build in the priorities from the Clinical Senate. And then we have 3 enablers that we have agreed across South West London, which is workforce, estate and capital, and digital and technology, which we will do at a South West London level. And then integrated care system is about how we're bringing together our governance for all of our providers and our system partners across South West London. So we will also set out how we will do that going forwards into 2021. So that will be the narrative of the plan, and then backing up the narrative of the plan, there are a number of spreadsheets that James, I think, has seen for all of us, that where we have to make some assumptions about what's going to happen with the money and the activity across South West London for the NHS, and we're working on that with our colleagues in the providers and across South West London. So we will have all of that for a first cut draft to be submitted to the regulators by the 27th of September. Then there'll be an opportunity for us to relook at that and check that we're happy before we actually publish that on the 15th of November. We're taking the approach actually that we want to do this in a very sort of a way in which we can present it to the public so it's readable, so it won't be a long document. The narrative will be quite short, and there'll be lots of graphs, and we'll be using some of the South West London sort of I'm trying to think what it's called. infographics, that's it, yeah, infographics. Thank you very much, Fergus. So we'll be using infographics so that people can see sort of percentages of things like diabetes and how that will work for South West London. So we intend to bring that back to you during October and before we publish in November for the final. And I think actually governing bodies are just before we go to final publication. So you will see the final draft. And on page, it is page 5, but it's not numbered, but page 5 of the report, you can see the timeline that gets us from where we are now through to the November date.
Right, any questions around the development of the South West London long-term plan? It's nothing new as regards, the basis is our local health and care plan, which then builds up into the South West London plan.
Yeah.
So any other comments or questions for Sarah? So we're quite happy with the direction of travel and the timelines that are being proposed? Yeah? Okay, thank you. All right, okay, thank you. So if we can come to the Integrated Quality and Governance Committee's in common report, please, thank you.
Thank you, Chair. I'm going to cover this today as Dr. Moore is on leave. I'm conscious also we've got quite a heavy agenda, so I'll keep my presentation short today with your permission. Contained within the report are updates from the July and the August Integrated Quality Governance Committee. And at the back of the pack is the most recent South West London performance highlight report, which relates to month 2. It's a few months out of date, so it's there for a comparator, but it is a little bit older than the other data that's contained within the main report itself. I'm really pleased to say that performance against most of our national standards and local metrics are being achieved, and all of our cancer metrics are back on track again, so that's been fully achieved. Referral to treatment performance, as we reported previously, is still a little bit below what the target is, and that is as a result of St George's Hospital coming back online with their reporting arrangements. There is a recovery plan in place for that, and we expect that as they get closer to the threshold, that the overall performance for Kingston will improve in line with that. I'm really pleased to be able to report the 4th consecutive month of improvement in our diagnosis rate for patients with dementia. We're now in single digits numbers of patients away from achieving that target. I don't have any further update to tantalise you with at this stage, so you'll need to wait until my next data set for that. The A&E performance, we had a good discussion, a more detailed discussion at the last governing body around that. And there are a couple of elements within the pack then which are new that we wanted to make sure the governing body was cited upon as they relate to the operating plan. So one of those we have included is the physical health checks for people with serious mental illness based on the practice registers. And we're very close to the 50% target that we have for that to be delivered in 1920. There are a range of actions which are in place and underway for us to get to a position of achievement by the year end, including the development of a new locally commissioned service for that. I also wanted to highlight within the report a little bit later on page 10 of the report about our performance in relation to continuing healthcare and personal health budgets. So personal health budgets are a strategy by which we can give patients and carers more control over how they choose to spend their health pound, if you like. We did very well last year, exceeding the target set. We had a new target set for this year, which was quite stretching, but I'm really pleased to say that we are ahead of our Q2 and almost our Q3 trajectory at this stage too. So some really good news in that element of the report. In terms of operating plans, supporting activity, I guess one of the big anomalies which jumps off the page is the outpatients procedures element, which relates to a change that was made after the operating plan guidance was published about unbundled diagnostic imaging. It's an anomaly, it's an artifact of how it's being counted. We're reporting it as it needs to be, but it's an unbundling accounting anomaly that shows the difference being, as you see, into the almost 100% variance on that. In terms of the clinical quality review groups, there are no issues that I'm particularly concerned about that I want to draw the committee's attention to. And we did have some very helpful presentations from Safeguarding Adults, Children's and Looked After Children, which I'm really pleased to say we're going to make some more time on the agenda for it later on, so I'll save opportunities for further narrative around that for then. But happy to take any questions.
Okay, I think one of the areas that that we have commented on before is around the dementia rates, and I think it's really good to see the numbers go up, although the actual LCS, which was meant to try and support it, hasn't even come into action yet. So do we have any idea why those rates have managed to raise up?
So you'll remember, I think in the January governing body, we had a very detailed presentation from Nerida, which some of it I think is going back around the loop of actions that we have taken in previous quarters and last year. And we also invested a little bit more into the medical and nursing support for that. So I think that is bearing fruition. Hitting the target is one thing. Hitting it with sufficient margin that we don't leave ourselves exposed to month-on-month or quarter-by-quarter variation is really what the ambition would be. So I'm still pleased that should the LCS demonstrate significant improvements, that it will create a buffer for us, that we're more confident and reliable in our proportion of patients who are newly diagnosed.
Thank you, Fergus. Any other comments around the report? No? So thanks a lot, Fergus. Thank you. Sorry, Rob.
The A&E waiting times.
That's a really good question, Rob. I think we're not unique in Kingston, and indeed at Kingston Hospital, in experiencing a higher level of demand for accident and emergency services. Nationally, that figure is about 5 to 6%, and indeed in the Kingston area, it's closer to 10% that we're seeing more this year compared to last year. We did talk a little bit at the last governing body about some of the things that are driving that, and there are a whole range of different factors. One of the things that we have talked about is the number of people who are working age adults who are accessing accident and emergency more than we have experienced in previous years. You're absolutely right. There hasn't been a significant change in attendances in relation to flu or outbreaks of anything like that. To suggest that that's the underlying issue. Very often when you create more channels of access for people to be able to openly access services, then people use them more. And as you know, not only did we open the urgent treatment centre, we also opened the short stay facilities within the hospital, both for general medical types of patients, but also for people with mental health problems, to improve their wait and their waiting times experience. And we also have significantly extended our hours of access for primary care too. So I think it's a challenge for everybody. The performance has improved in the last couple of weeks compared to the time period within the report. But people are attending in large volumes, and the achievement of the 95% standard is proving a challenge within the Kingston system.
Yeah, right, Nico, I just think,
No?
are we obviously need that.
So we cover it probably in light detail here in terms of the overall performance report, but rest assured the A&E Delivery Board, which meets on a monthly basis, and in terms of our governing body, both Naz and Tonya, and commissioning management teams are part of the team who would be engaging with the A&E Delivery Board. It includes social care, it includes the community providers and the acute trust. There's a lot of work that happens within that arena that I wouldn't necessarily be able to cover in sufficient detail here.
So there is a piece of work actually going into the detail behind the attendances to actually look at the reasoning behind why people are attending. Just only to make sure that we haven't got any gaps in the services that we need to provide. So there is a piece of work that's actually going on looking at the data and actually getting the feedback from the patients themselves. Yeah. Yeah. Yeah, no, agreed. Okay, thank you, Fergus. Thank you. And was there anything else you wanted to highlight as regards the South West London performance report, or are you quite happy for that to be taken?
No, it's there for information.
Okay. James, the Finance Committee. Neil?
So the Finance Committee met at the end of July. We reviewed the month 3 position. We have included the month 4 position in the governing body papers. The main discussion we had at the committee was reviewing the month 3 position. We also did a deep dive into some of the areas where we weren't up to plan on QIP. And then the final bit of the discussion was on how we develop the financial plans for the long-term plan, which we've talked about earlier on in the agenda. If I pick up the month 4 report, I was going to suggest if we looked at page 82 in the papers, that's slide 5. These were just the main summary points. So as at month 4, we're still reporting to meet our break-even position. The financial risks are at the moment about 2.9 million. We have got areas to mitigate those financial pressures. And the underlying deficit is now at 2.03 million. It has deteriorated significantly since the beginning of the year, partly because of the amount of non-recurrent measures we've got in the position at this stage. And then the final point on the left-hand side was we're now forecasting not delivering the QIP target by about 600k at this point. I think the two areas where we're largely behind are on the CHC, where we're starting to see a reduction in the amount of benefit we're getting from no longer eligible patients, and also in the outpatient transformation, where we were expecting to actually be delivering some of the plan at this stage, but we've still got that cost. Just a couple of the year-to-date positions I was going to pick up. If I take you through to page 86 here, this gives you the summary for, 86 gives you the summary for the South West London position for the Kingston Hospital contract. And you can see on the right-hand side, overall, although the contract is over plan for the whole of South West London by 776,000, it's within the 2% tolerance that we have within the contract. So at the moment, we're 98k below that tolerance level. The thing I just wanted to highlight from a Kingston perspective, which is the second column on the left-hand side, the main pressure is really continues to be with critical care. That has reduced marginally over the last couple of months, but we have this quite large critical care pressure coming through in Kingston Hospital. The only other acute pressures we have are with St George's, which is largely to do with plan care, and some pressure with Guy's and St Thomas's, largely to do with critical care and maternity as well. The other bit I wanted to just focus on is also on page 91, which is the CHC area. These graphs on the left-hand side show you the numbers of patients in the top graph and the monthly spend of CHC. And if you can see the increase in spend over the years, we've looked at the actual spend in month 4 compared to the same spend in month 4 of the previous year. It's increased by 33% overall, and you can see the largest area of growth is that yellow line at the bottom. The palliative care has significantly increased in terms of numbers and just the cost of palliative care over the period from the start of the year. Now, this position isn't replicated in Richmond. We have a very different set of profiles in Richmond, so we're trying to understand why we're experiencing this pressure in palliative care and also in physically frail in Kingston, and it's not really showing up to the same extent in Richmond at all. Those are the main things I just wanted to highlight.
Okay, thanks, Neil. I've just got a couple of questions, if that's okay. As regards to critical care pressures at Kingston, is it one particular patient, or is it a particular complex patient? Or
there have been some complex patients. A couple of them were actually admitted in the previous year, and so we are currently seeing the costs. So there may be a potential reduction in the balance when we get to the year end. We're trying to model that through, but there have been quite a lot of patients who've had quite a a large number of organs supported for a large number of days. And in addition to that, we've also shown this overspend in critical care at Guy's as well. So we do appear to be using not just the critical care beds disproportionately for Kingston CCG and Kingston Hospital, but also overflowing into Guy, or there is certainly activity going on in Guy's as well.
Thank you. And just one other question, if that's okay. Coming back to the fast track palliative care patients, is it, I mean, like sort of comparative to Richmond, because I know Kingston were quite far ahead in progressing with the CHC. Is it because you've reached a specific limit in the proportions of the fast tracks are starting to go up compared to where they were before? Or I just don't understand the reasons for it, behind it.
So we've never had a particular challenge in the Kingston footprint about the appropriateness of fast-track referrals. And our evidence of that is that 3-month reviews, a very significant of those would have, because it was expected, would have been in their end-of-life care phase. So it's a pure numbers increase really within this. What we haven't seen is a large volume increase, but people who are then living much longer beyond that end-of-life phase. So I think it's a legitimate increase. And again, with fast tracks, there isn't a choice to be made about eligibility. If they're referred, they're critically ill and rapidly deteriorating, there's an automated authorization process that's in line with the national framework for that.
So you do get these things sometimes, don't you? A little bit of a blip or something in the numbers. What we'll need to check is whether or not that is consistently increasing, and if it's staying there. You sometimes get that, and it might be the hot weather, it could be anything that means that you've got an increase in end-of-life care at a particular time. I think if it does start to continue, I think there's a question about, is there a demographic question in Kingston that's coming about at this point, and therefore what's our pre-planning for that going forwards, and do we understand what the demographic is? So I think that's just a different question. As long as we're confident that there's no change in the actual appropriateness of those, then I think then we have to start asking some of those questions.
Okay, thank you. Gareth.
It's just a quick question about the critical care. I mean, at Guy's and Tommy's, are we talking, 1 patient, 2 patients? Are we talking 10 patients? Is it?
It's less than 10 patients. We don't send an awful lot of work there, but we have a very small contract, and therefore if we are marginally over, it has a big impact. I can get you the data, Gareth.
Yeah. Thank you.
Okay, thank you. Any other comments or questions for Neil? No? Okay, Neil, thank you very much. So if we can come to the back, please, Vicky.
Thank you. You have in your papers the summary of our risks and a more detailed risk register. We have 32 risks, none with a residual risk that is very high, i.e. that it's very high by the end of the year. We've got 7 new risks on the list. One is around the delivery of the management cost reduction of 20%. The rest are around all around primary care. They're draft because these haven't been through the primary care commissioning committee yet, but we've refreshed all our priorities in primary care and updated the risk register to reflect that. As you'll know, each of our subcommittees takes responsibility for risks pertaining to their agenda. 3 of the risks are closed, 2 are around primary care because we've adapted them. 1 is around health and safety. We haven't taken our eye off the ball with health and safety for staff. We've just put it as part of our staff engagement priorities. So there hasn't been much change other than that. The executive management team continues to scrutinise all the risks, controls and actions on a monthly basis.
Thank you very much. Comments or questions for Vicky around the BAF? No? Okay. Thank you very much. The councillor members' report is there for noting. I know Atin's not here. I just wondered whether members have any questions around the councillor members' report, which includes the 2 meetings that have happened since the last governing body meeting. No? Okay. Thank you. So can we come to the PPE documentation? So the annual review.
That's me, and then
Yep,
I think Jim
okay.
might want to say some comments afterwards. So we don't, as a CCG, we don't have to do an annual report anymore of our PPE activities, but we find it a really useful thing to do, and we get good feedback about collating all the activities on an annual basis. So you've got the year's review in front of you. We were pleased that we maintained our green rating from NHS England's Patient and Community Engagement Indicator. We achieved a rating of outstanding in 3 areas. One area is requiring improvement, and that's on feedback and evaluation, and that's going to be a priority for this year in looking at that. We've increased and strengthened our working with partners both across Kingston and also across Kingston and Richmond with our work on the health and care plans. And we continue to have a very strong relationship with Health Watch and KVA in particular. I think many of you attended the engagement events that were held in November, and that's given us some really useful feedback for all partners in developing the health and care plan. We also continue to support our staff in ensuring that all commissioning decisions are underpinned by effective patient and public engagement. We've visited 26 different groups across the borough. We've heard from over 750 people, and we've engaged with 60 local people who haven't engaged with us before, and we've done that particularly around the engagement that we did on the health and care plan, because we used a different way of recruiting people to give their views, and that was really good. A highlight of the winter was our Winter Champions project, where many of our staff took the opportunity to go and visit community groups and voluntary sector organisations. Tonya and I played bingo, which was probably the best fun we'd had in the winter. But it really does connect our staff with the community in a very meaningful way, which is really nice. So the priorities for the current year, as I said, we want to strengthen the feedback and evaluation piece. There'll also be more work pertaining to the health and care plan. And we also want to look at the development of patient and public engagement in primary care, looking at GP practices that have patient participation groups, sharing best practice, but also starting to work with the primary care networks when they're ready to increase patient and public engagement. So, Jim, I don't know if there's anything else you wanted to say.
Thanks, Vicky. I was just going to make a couple of points. First of all, Chair, if I may, just to thank the team who've worked on this year, because as Vicky says, we've not only maintained our good rating, we've also got some outstanding elements to it. And I just wanted to thank Caroline O'Neill, who's been leading the team in Kingston and Richmond, and Joe Austin, who's just actually left us to be replaced by Hannah Keats, who's returned from maternity leave. But I think they've done an absolutely brilliant job this year. And also just to say, looking to the future, that there are some very active conversations around how the patient and public voice will be represented in the new arrangements, because they will be different. We will have one CCG at South West London level. I can confirm that there will still be a consolidated group at South West London level, which will be formed of representatives from all the constituent boroughs, and that perhaps a slightly more formalised borough level patient and public group will be there. And the reason that Liz Mirabau isn't with us this afternoon is she's part of those conversations at South West London, which I would be if I wasn't here too. Okay, thanks.
Thank you, Jim. Any comments or questions as regards the document and the review? I think it's a really good piece of work, and the way that this is set out shows all the good work that has been done. So I think it is just making sure that we pass on on our thanks to the team that have worked really hard on this. So any other comments or questions? Rob. Thank you. Any other comments at all? All right, thank you. So, Stephen, about the Health Watch.
Thank you, Chair. We do have to publish on an annual basis still on the 30th of June, and thank you for inviting us here today to actually sort of give you a brief update on this. I'm presuming everybody's read the actual report itself at this stage. I'm not going to actually sort of go through it in detail, but I would like to just sort of lead you to page 7, where we provided a bit of a sort of diagram there, which is kind of illustrating the ways that Health Watch Kingston is now working with our partners in the community and the types of kind of projects, community task groups, hospital services task group, mental health task group. Youth Out Loud has been mentioned in the previous report. I'll come back to that in a moment. And we've just established a learning disability task group. There are two darker highlighted boxes in that particular diagram. Both of those are where we're providing an independent chair to key strategic pieces of work within the actual area, one being the Kingston All-Age Learning Disability Strategy and the other being the Thrive Kingston Mental Health Strategy Planning and Implementation Group, and work on that is ongoing to sort of review the or reprioritise, I suppose is the best way to say it, the actual sort of priorities for delivery over the remaining time of the strategy, as we're about halfway through at this stage. So we're working with the CCG and RBK and other stakeholders to look at that over the coming weeks. If I might flip you to page 29, as I'm not going to go through what we did last year, that's all laid out in the report. I just want to highlight some of the top 5 priority work areas we have for 2019-20. Again, you'll note that the priority areas have remained consistent from last year to this. So mental health, learning disability, hospital services, community care and young people. So with mental health, we are continuing to, we're continuing the survey really of the iCope service. We've agreed with the CCG that we will run this for a little while longer and then feed back the actual information into any necessary commissioning rounds as they appear. The key project for this year's work within the mental health task group is the review of the transition of young people from CAMS into adult services. Learning disability, that work has now been nicely bedded down by Scott, who's our learning disability projects officer. We have had several meetings of the All-Age Learning Disability Partnership Board where we have engaged with not only providers of services, but we're encouraging people living with a learning disability to attend that particular forum to share their views on various progress against the strategy. We've established also, as I say, the Learning Disability Task Group, which is a similar structure to that of the existing task groups within Health Watch Kingston. Hospital services, community care, what else do we have? Youth Out Loud. So Youth Out Loud was established last year, as you'll know, and we were very keen to sort of build upon the actual large piece of work that was done across both Kingston and Richmond, where we engaged with about 1,600 young people, asking them what would improve their mental health and well-being. Out of that came clear instruction from them, requests that we engage them more in the things that we do, and therefore we set up a task group. We started out by calling it rather youth-friendly, the Youth Health Task Group. They kind of changed that rather rapidly to Youth Out Loud with the exclamation mark because they wanted to shout about it. And we've actually been working with them since to facilitate those discussions across both Kingston and Richmond. So we're doing that piece of work in partnership with Health Watch in Richmond and other key stakeholders from both boroughs. I'll stop there. Any questions from anybody, if that's okay, Chair?
Right, okay, so thank you very much, Stephen, thank you. I've got a couple of questions around this, and maybe Fergus might be able to help out with this. We are looking at trying to look at an awful lot of feedback from different organisations with something called Make a Difference going forward. Do you know whether Health Watch might be involved in that to try and get feedback into that loop, or no?
So currently the plan would be it's more of a professionals line rather than somewhere where a member of the public might contact Health Watch with a concern or a requirement for some support. So there isn't a vehicle but through that. We would use the patient advice liaison services primarily for providers, or indeed just going back directly to a GP practice, for example. So at the moment, that framework is designed specifically for inter-provider professionals to resolve an issue.
Thank you. And the second question was around the Youth Out Loud. Do you link in quite closely with the Youth Parliament at the Borough as well on that?
Yes, we're the Kingston Richmond Youth Council is the key organisation that we sort of work alongside. The Youth Council itself doubles up as a bit of a steering group for Youth Out Loud from young people. So the majority of people that currently work with us in establishing the actual structures through which we'll engage are engaging in both the Youth Parliament and so on. So each time a new Youth Parliament is elected, we're getting a fresh group of young people involved in the discussions we're having. So we're trying to build a bit of a sustainability into the process. So, I mean, they've been doing various workshops around sort of what makes a difference to them. So in as much that primary care came up around youth-friendly GPs, youth-friendly pharmacies. I mean, the usual things that we've been hearing for quite some time. So nothing new, but we're just getting a reaffirmation of that particular point of view. I did want to make one other, just in regard to patient participation groups. I have met with Hannah Keats recently, as you know, Vicky, and we're sort of very keen to ensure that Health Watch Kingston builds a better relationship with our patient participation groups, particularly in light of the primary care network restructuring. And I think we're looking to set up some initial meetings to talk to some of our patient participation groups to see how we can better work together. There's obviously national guidance from Health Watch England and also the patient participation group guidance that allows us to be sort of supportive of each other so that we can actually sort of learn from each other and sort of have a more a joined up approach, I suppose, to the work that we're doing.
That's really helpful. Thanks, Stephen. Any other comments or questions for Health Watch? Yes, Iona.
Just one typo for me, if possible, Stephen. On your community care, one of your priority areas is evaluation of Connected Kingston rather than Connect Well Kingston. I think it was part of the feedback from people that Connected Kingston resonated with them more. So if it's possible to amend that to Connected Kingston rather than Connect Well Kingston, I appreciate it. Thanks.
Thanks, Iona. Any other comments or questions? Okay, Stephen, thank you very much for that. So can we come to the safeguarding annual reports, please, Fergus?
Thank you, Chair. So first of all, I'd really like to welcome Andrea Nock to come and talk to us about the Safeguarding Children's Annual Report. Andrea is our designated children's safeguarding nurse, and the report here is to give us some feedback on what's been happening in the previous year and to look at priorities for the coming year. So really interested to have any feedback for any areas for improvement. Well, without further ado, I'll hand over to Andrea.
Can you hear me? Okay. Good. Okay. Closer. Okay. Is that better? Okay. Thank you for the opportunity to present my report. Just like to remind you that the purpose of the report is to provide assurance to the CCG and the governing body that the organisation is completing its statutory role within safeguarding children. So without further ado, I'll just draw you to some salient points within the report, because it is quite a long report. So I'd like to draw your attention to page 7, where we discuss the number of children subject to a child protection plan. We're quite lucky within the borough that this doesn't really fluctuate too much over the years, and just as in previous years, this has remained quite comparative. We are below the national statistic, but we are very close to our statistical neighbour, that being Richmond. There is still a scrutiny panel which looks at the thresholds of children referred into child protection to ensure that the thresholds are met and all children are viewed and processed in the correct way. So that still continues. Currently, there's no pathway for sharing local safeguarding updates with dentists and optometrists, but we are doing some work with our dentists at the moment to see if we can see if there's more children out there that we're not reaching. I'll draw your attention to page 8, where we look at the child in need plans. Children in need are those children that don't meet the threshold for a child protection plan, but still have needs. It looks like a huge number at 909, but that's all the open cases across Kingston. This has risen a little bit since 2017, 2018, where it was 766. But you could argue that's a good thing because we're getting to children at an earlier time, so this earlier intervention. We still remain lower than our statistical neighbour, and we are still lower than the national average. Can I draw your attention to page 16, where we look at the child death overview. Following a review of the Working Together to Safeguard Children statutory guidance, it was published in 2018, we now have to look at the process for child death review, and it has changed quite significantly. A considerable amount of work has been carried out, and after new child death review partner arrangements are set up, Kingston and Richmond CCG areas have a statutory grace period of up to 4 months to complete outstanding child death reviews. Sometimes child death reviews are delayed through the process because there may be a coroner's report that's being awaited. So it's not unusual to have outstanding reviews because we have to wait on that piece of work. So we are required to have these completed by the 29th of January 2020, and I can assure you that work has been ongoing around this, and we are on target. Excuse me, I've got a frog in my throat. You'll see from the table that we have quite low numbers. For us, joining with South West London to do the review will actually allow us to do some comparative work, because with only 16 deaths per year, it's really hard to extrapolate any themes. So we're viewing it as quite a positive. Going on to page 17, just a mention of the serious case reviews and learning lessons reviews. Again, this has been affected by the review of the statutory guidance in Working Together to Safeguard Children 2018. There is now a national panel for serious case reviews, and it will be themed. The current theme is knife crime, which I'm sure doesn't surprise you. So the LSCB has overseen only one serious case review using the old format within this time period. The report wasn't published because for fear of identifying the family and the young child, but all the lessons learned have already been embedded and taken forward throughout the health economy. And the neglect tool, it's an assessment tool, has been reviewed and is being widely disseminated. So we see that as a positive. Just taking you forward to the leadership, we now currently have everybody in post that is statutory required, except for a named GP. I'm glad to say that we have appointed a named GP, and they will be starting in October. So come October, we will have everybody in place. Let me just draw your attention to SEND, but I think that Tonya did give you quite an update on SEND, so it's just to let you know that it is part of the work plan going forward for safeguarding team, and we will be very pleased to work with the DCO when they're in post on the 9th. And I'd just like to say thank you for listening and ask if there's any other questions. You'll see from the back that we've made quite considerable progress on the priorities of last year, and the priorities for this year are listed. So any questions?
So just to add briefly, the report period 18-19 was a challenging year for safeguarding children. Particularly challenging for Andrea, bless her. And we during the year we needed to secure the services of an interim over the course of the year. But notwithstanding those changes, since Andrea's returned back to work, we made significant progress, both with the development of our new local safeguarding children partnership arrangements for child death overview arrangements as well, which the first meeting was just this morning. That's where Andrea was this morning. But I wanted to also just take the opportunity on behalf of the governing body to wish Andrea all the best in her retirement. Andrea's shared with us just recently her decision to retire from close on 40 years of service within the NHS. A fantastic career. She's been a tremendous asset to our local partnerships. And remember, the most important thing when looking to keep children safe within the community, it is partnership working. And Andrea has been an outstanding advocate for us as a CCG in maintaining those relationships over recent years. So I want to just take the opportunity before any questions to say thank you to Andrea and wish her the best in her retirement.
Thank you, Ben. Didn't appreciate 40 years. Wasn't quite 40 years, may I add?
Almost.
Age in it. Oh, sorry, have you a question?
No, if I can just go around the body. So I just wanted to just reflect on what Fergus has said, and thank you from the governing body and the CCG for the immense amount of work that you've done over the years, providing the safeguarding reports as well. So questions, Gareth?
I'm sorry to be retiring too. I just wanted to go back to on page 7, you talk about the general practitioner reports. I know that there's
Oh, yes.
difficulties in GP attending because there are normally clinical time, and that can be tricky. But it's also about the submission of the reports from GPs, where I'm sure everyone knows that GPs are asked for their input on families and children that they're interested in. I'd like to hope that no one doesn't fill these in on purpose, but I'm just wondering if there's any way of feeding back so we can try and work out why we're missing out, because I know that I do every one that I see, but I don't know if there's any way that practices could have to be fed back as these are the ones you missed out on, and how were they sent to the practice, and how was and why were they missed out. That may be helpful for practices because we may not be knowing about the ones that we're missing.
Yeah.
In the old days they were faxed, and then the faxes were lost. I know they're emailed now, so things should be more traceable.
Yeah. I mean, thank you for that. That's really relevant. And I'd like to just update you that we are actually doing quite a considerable piece of work around that. And just next week, I'm going to be doing an audit with social care, so with the manager of the case conference chairs, to look at how many reports, so how many were requested within a time period. We've gone up to 10. So how many were requested, whether they were filled in, and then ultimately try to trace back and look at the reasons why they weren't submitted. And it may be something as simple as they don't have the correct address, maybe they've not updated their contacts. There could be something quite simple. I've had a meeting with GPs recently and they feel that they are submitting across Kingston, and yet that doesn't seem to be the story we're getting back. So I think there's some real deep dive work that we need to do there to actually understand it a bit better.
Fergus.
So I completely agree, and I think that root cause analysis work that we're doing across Kingston and Richmond will be really helpful in us identifying what are the actions that are most targeted for the most improvement. I do think there's possibly some technical solutions that we might be able to put in place as well, using EMIS and Vision in a different way, that we might be able to pre-populate at least some of the forms, extracting from the GP record as well. And I do think there's probably some administrative support that we might want to think about for Kingston and Richmond. Sometimes the diary invitations or the diary coordination or the email reminders, something practical like that. So a combination of those I think will be helpful. But first steps were the root cause analysis to establish what we might do most helpfully.
So I have heard this in other areas across South West London as well, that there is, and I don't know if this is true in Kingston Richmond, but it would be interesting to find out whether we've got a similar issue, is that the number of requests are increasing quite significantly, and there's not a lot of clarity about why, or actually understanding why the requests are being made, and therefore general practice is really struggling with actually responding in a way that is very helpful. So I just wonder if we want to build that into some kind of review of understanding some of that, so that we can actually do something that's really worthwhile, because I'm sure general practice does want to respond, but if they're getting a lot of increase in requests and they're not really sure why they're being asked for this, it's quite difficult actually. So I think it would be helpful, because we've got that in other boroughs as well.
Yeah, you're absolutely right, and that was brought up within our meetings. And I think there is also a confusion because the form looks the same. The request form is the same for any piece of information that's being asked for, whether it be a report, whether it be a review report, or whether it's for information. So there is something that we're going to do with our local children's services to try and make it, if we do one form fits all, then it needs to be a usable form that's usable to both sides. So we're trying to do some work on that.
Okay. Yeah,
and I think one last piece, just because I think Sarah's making a really important point, I think it's important that we also feed back the outcome of the review, because actually if you recognise that it's making a difference, it makes it really relevant. And I think it would also help us ensure that the referrals or the requests are coming through and there's something happening as a result of that. But I think we can definitely build that in. Thank you.
Thank you. Any other comments or questions? So I just had two two comments, if that's okay. Well, one's a question. The children in need, you said that actually the numbers are below the equivalent for a statistical borough. So,
Yeah.
I was just wondering, are we assured that we're not missing people because the numbers are lower or not?
As much as we can be,
Yeah.
because with the scrutiny panel, it also looks at the children in need referrals. So it looks at whether they're appropriate referrals, if there's any more work that can be done. We've just started doing regular sort of updates. We're trying to reach out to the community generally. So in reaching out and doing sort of seminars and talks around what the general themes are, we're hoping that the general education across the piece is being raised. So I'm fairly assured. I don't think you can ever be fully assured, but I'm fairly assured that that's reasonably accurate.
All right, thank you. And the second bit was around the child death overview panel. And are there ways, I mean, you talked about the numbers being quite small, so themes were really difficult.
Yeah.
But are there ways of being able to share learning across the different boroughs?
That's what's going to happen now. So our South West London will include the 5 boroughs. So there will be some comparative work that we can do there. But also the aim of it is that there will be a national panel. So themes that happen with us may be common in other cities, in Manchester, Leeds, wherever. So there will be some shared learning, not only across sort of the London boroughs, but also across the country. That's the whole aim of the review, really.
Thank you very much. Rob.
First one is a Rob's stupid question, but do you only deal with safeguarding for health problems? Is that right? Or?
No.
Because obviously we've got a lot of flats in Chesterton that's got a drug dealing problem,
Yeah.
and there's young children in those flats.
Mm-hmm.
And so do you liaise with the police?
Yes, absolutely. Yeah.
The police do and are aware
Yeah,
of it.
yeah.
And secondly, is it a legal obligation that GPs and A&E, if they see a problem and they think it might be a problem, are they obligated to actually tell you, or is it just a discretionary thing?
Yes, they absolutely are. If you see a safeguard, as a professional, if you see a safeguarding issue, you are obligated under your professional registration to do the right thing, which would be to refer or to inform the right people.
So are these things implementary for safeguarding for Kingston Borough, or is there a safeguarding department in Harvey County as well?
There's never one person doing safeguarding, it's across the piece, it's multi-agency. So whilst I represent the CCG and obviously liaise and support with all my other colleagues within safeguarding, I'm not the only person working in safeguarding. You have police, education, local authority, even voluntary groups. I mean, the list goes on and on and on. So, yeah, so, all right. So I'm not the only person. Gosh, I'd be exhausted if I was. But, you know, we are part of a multi-agency team. I'm afraid I am. Yeah, it's not quite 40 years. Can I just stress that again? It's not 40 years. It's actually 38. He exaggerated.
It was almost.
You know.
I thought it was going to be 30.
Give me 2 years.
Fergus.
So Rob, just to be clear, if somebody has a concern about a child in danger, on the local authority website, there's useful information about how to make that known. So we wouldn't normally receive directly referrals or a concern about a child in a block of flats, for example. It wouldn't normally come through into the CCG. We might hear about it through different means, and we would act upon it. But the local authority have the coordinating role in terms of receiving in notifications for concerns. The other thing within the report, it's important for the governing body members to be aware, the legal framework has changed. So the footing now is for both the police, the CCG and the local authority are equal statutory partners. In the past, the local authority took the lead on this, but we're now regarded in terms of statute, we're equal partners and have obligations commensurate with that.
That's great, thanks a lot. I'm just going to hand over to David because I'm just going to pop out for a couple of minutes for the adult safeguarding report. Okay, thank you very much, Andrea, and all the best for the retirements as well. Okay, thanks. Yeah, you're 38 years.
Right, can we then move on to the next item, the Adults Annual Report, Safeguarding. And Peter, Fergus, you want to kick it off?
That's correct, yeah. Peter is here. Peter's our designated adult safeguarding lead with his annual report.
Am I switched on here? Can everybody hear me? Yeah? I'm Pete Warburton. I'm the lead for adult safeguarding at Kingston CCG, and as Andrew said before, our annual report, is showing you that you've got assurance from us we're meeting our statutory responsibilities and obligations in regards to adult safeguarding. I'm going to cover 6 points in the report, not going through it all in detail, but what I wanted to say is that my colleague Sarah Loads works across Richmond CCG, and even though we work in our own sovereign boroughs, we work towards our specialities. So mine is in mental health and learning disabilities, and Sarah's is MCA and DOLS and acute, anything to do with acute. But we still cover all the areas within our boroughs, so I just wanted to say that. So looking, if you move, talking about assurance first of all, on page 9, we've been working together with our other CCG leads across the South West Borough, thinking ahead. We wanted to have a standardised reporting mechanism because we've had different reporting mechanisms in the past. And I think it's been quite difficult for our provider commission services to give us the information that we needed. We've been asked for lots of different things. So we've worked together and we've developed a standardised document now. We've still got a few teething problems, but it's working. It's a qualitative and a quantitative document. So that's the first thing. I'm also involved in the Mental Health Trust Safeguarding Committee, and within Kingston Hospital, when we have issues that are not quite as safeguarding, but they are still a problem that need to be addressed, we're working with Kingston Hospital and the Cause for Concern Forum. And going on from that, looking at care homes and domiciliary care providers, we work with the borough and all of the partners for the Kingston Joint Intelligence Group, so that's where all information is shared in regards to our community services and care homes for older people and nursing homes. So just moving on, to page 11, looking at the Safeguarding Adults Board. We've had full attendance at the Safeguarding Adults Board. We're very active partners within the board. I chair the communications subgroup, and we had one of our priorities from last year. We were looking at the data that we received from Safeguarding Adults, and one of the groups of people that had the most referrals are older single women. So we wanted to do something around that. So we did some preventative work, and we went out and did some presentations on adult safeguarding to stay well. We also had the mental health carers group that we went to, and we actually did a huge event here for the summer club for older people. So that worked really well. But that's still an area where that's still a priority for next year as well. So that's a little bit about the board and the communications subgroup. In regards to safeguarding adult reviews, in the last year, we've had 2 completed safeguarding adult reviews. So that's looking in detail where a person has either passed away or suffered serious harm. And out of those safeguarding adult reviews, we've had 2 learning events, quite different learning events. The first one, there were more partners from all different services involved, and we actually had the partner of the person who died come to that learning event. That went really, really well. And the second one, there wasn't so many services involved, but we still did that, and that also went very well. So that's about learning from safeguarding adult reviews. Just moving on to page 16, I wanted to talk a little bit about the Learning Disability Mortality Review. This is a national programme scrutinising and looking into the deaths of people with a learning disability. So everybody with a learning disability will be referred to this programme, and I am the local lead, the local area contact, and I lead this within Kingston, and my colleague Sarah leads within Richmond. I chair our local steering group. In the past, there's been some issues nationally about the amount of reviews being completed on time. There've been some places have their reviews been very behind having their reviews completed, but actually within Kingston and within Richmond, we've achieved on the red, amber, green rating scales, we've achieved green, and we were commended by NHS England earlier this year for the work that we've done. And it's great to know that we're up to date with all our reviews, but now what we're going to focus on and prioritise for the next year, and we've already done some work around this, is embedding the learning, because it's okay to do the reviews and get your reviews up to speed, but so what? So that's our next piece of work. We've already done something about that. We've already had a learning event at Kingston Hospital. We also did last year, we had a little tiny bit of money, and we worked with Richmond Mencap and Kingston Richmond CCGs and NHS England, and we produced a small film looking at what is the mortality review about, its importance, and also supporting GPs around the importance of annual health checks for people with a learning disability. So that was something, a great piece of work that we did last year. And moving on to page 17, sorry. Tonya mentioned in regards to modern day slavery, we've got a statement now on the CCG website, but modern day slavery is on the increase, and part of my role is to ensure that we're linked in with all the rest of London. So I attend the London Network Safeguarding Leeds, the Modern Day Slavery Safeguarding Leeds Network. So I ensure that anything that comes up there is brought back into Kingston and vice versa. And we have actually had an increase in referrals, not a huge increase in referrals, modern day slavery. So that was that. And just a final little bit on page 18, I wanted to talk about partnership working. And we're thinking ahead about how the CCG is changing. So what we've done is we've set up across the southwest sector Safeguarding Adult Leeds Forum. So that's for all our health partners. So that's all the acute trusts, all the community trusts and the mental health trust. And we've also got the leads from the local authorities of Safeguarding Adults Leeds. So the purpose of the forum is to address any practice, performance and operational issues arising in safeguarding practice in the health economy, but also in the social care economy. And we're also looking at sharing good practice. So it's not a forum whereby we're looking at people and monitoring them and getting assurance. It's a great forum where we can actually, if there's a problem arising, we can sort that problem out before it goes too far. And it's also working across the piece. And that's with all our other partners from the other CCGs. So that's something that's working really, really well. And I think for the moment, there's lots of other areas that I wanted to talk about, but we've not got time. So I'm happy for you to ask me any questions on anything that you like, if it's in that report.
That's really helpful. Thank you so much, Peter. That's it's a really informative document as well. So thank you very much. Fergus.
So I just wanted to also mention that at the next joint governing body seminar, we're going to take the opportunity to update all of our colleagues about some of the more detailed obligations that we have as a governing body about safeguarding adults and safeguarding children. They promised to make it fun as well as interesting, so I'm looking forward to that one. We've talked a lot in other forums about the opportunities that moving forward together will bring for CCGs and staff. And I think really what I'd want to just draw the governing body's attention to is the way that Peter and Sarah have worked together is very much in the spirit of the local delivery unit. But they've been working ahead of the curve, if you like, in comparison to other parts of the CCGs about cross-cover for each other, about taking a lead on something across South West London, or working collaboratively in a very different way. And one area that I would just signal a really good outcome of that is the learning disability mortality review that Peter talked about. So South West London is the highest area in London for notifications, but we are also the best performing in terms of the allocation of reviewers to those reviews and the timeliness of those reviews. And I think that's testament to the work that Peter and Sarah do on our behalf here. And Peter is an absolute champion for people with learning disabilities in our local area. I wanted to just take the opportunity to thank him for his excellent annual report.
Thank you.
Thank you very much. Sarah.
So interesting, we had a bit of a discussion in Richmond earlier this morning about this, and we had highlighted to us sort of areas that were specific issues for Richmond. Are there any areas around adult safeguarding that you think these are specific issues in Kingston that we would want to know about as a governing body?
So we had the first VARMA panel, which is a vulnerable adults panel, yesterday, and because for whatever reason, I ended up chairing it at the spur of the moment. It was really interesting. It was really good. It's the first one that we've had. Richmond have been having them for quite a while. So many different issues, and when people bring a case to VARMA panel, they're really stuck because they've tried all avenues. Issues around younger people and homelessness. And this is older adults, older children in transition, and also younger people being targeted for gangs. So I think that's an area that we need to focus on: homelessness, younger people in homelessness, and also their vulnerability and being targeted. One particular chap, how he's being used for potential drug running and other things. So I think that's an area that we need to to work together with children and adult services. Those younger people who've fallen out of school, people with ADHD, with the diagnosis of ADHD, they seem to be a great area of need, and homelessness. And that's why I was also talking about modern day slavery. If you looked at this young chap in that respect, you could also put him under the banner of modern day slavery.
So it comes through maybe a little bit more in the data section within the report, but 85% of safeguarding events happen in the community and are perpetrated by people who are known to the victim. If you are elderly, if you are white, if you are female, you are more likely to be a victim within this area. And everything that we hear and see within the news is happening within this locality. So we've had a case of modern day slavery in Kingston Hospital for a person who it then becomes difficult for us to work out what the health responsibility are, because they're not entitled to health services. And the local authority will also say they're not entitled to housing as well. But here we have somebody who is a significant victim, socially isolated, financially isolated. It's a real emerging area, and an affluent area like Kingston, you will find modern day slavery in the guise of housekeeping and cleaners and other areas as well, not just the things that we think about in areas like Birmingham and Croydon, where it has been highlighted around car washing and nail bars and the like. Some of these things are in plain sight within the Richmond area. But if your focus is going to be on it's single, white, female, elderly, they're the most at-risk groups that we have within our Kingston area.
And the only other thing I've mentioned is around the financial scams side of things.
I forgot to say that, yeah.
So if I said the figure that we have been talking about in the Richmond area is about £35 million in a year, financial scams, it will be a commensurate figure for Kingston. It is a massive issue. It's very often hidden because people are embarrassed or ashamed about falling victim or falling foul of somebody who is very clever. And particularly within healthcare services, we have had people scams which have involved perpetrators acting as either pharmacists or GPs as part of their ruse to gain confidence of the individuals. So there's a lot happening within the safeguarding area.
Those two are the main areas would be for younger people and homelessness and scams. Those are our main targets for next year, and and past that, I would imagine.
So can I just ask a question then on the scams, because there's an awful lot of media coverage around the scams themselves. So is there anything? Do you feel there's anything more we can do to try and improve the knowledge base of the?
I think the work that we've got planned, if we follow what Richmond have done, is the scams events, putting things up online. But older people don't use the modern internet technology as other people do sometimes. So it's actually like we're trying to do to get out to the community group. So I've been to Kingston Voluntary Action the other week to do a general discussion with their members there, who then go to their groups. So from the Safeguarding Adults Board, what we will be doing is going directly to see people. That's the best way to get messages out, and to community groups and to church groups as well. So that's the best thing to do, because not always internet gets to older people.
So we also spent some of money with the police in partnership around creating a short video, which is available on Facebook.
I don't know whether we've included the link
within the report, but we can circulate that. And one of the things we did was include subtitles at the bottom of that. So I know that Peter and Sarah were planning on all GP practices having this. So in your waiting room, on your television screens, you can play it on a loop. But with the subtitles, it was so that people... the noise wasn't intrusive within the waiting room. So there's some additional information that we get, which was very targeted in the Kingston Richmond area, that we led on. We can share that, and that could be presented in GP waiting rooms while patients are waiting. Captive audience, and a really helpful 10-minute clip about some of the things to watch out for, some of the things to be aware of.
Can I just ask one more question before I come to Naeem? So as regards to homelessness, is there a real problem with them accessing healthcare itself as well? Because there is a big London-wide ability. Sorry.
So Tonya will be able to answer the homelessness question, but can I just say, because I've just my personal experience, as part of Winter Champions, which we talked about earlier, I went to a homeless group in Kingston, and I spent the day with them, and the biggest issue that they had was dentistry, strangely enough, and accessing dentistry. They could actually get access to a GP, and they could obviously get access to A&E, but their biggest issue is being able to access dental treatment, which I think is quite an interesting one. But anyway.
Okay. Thank you. Naim.
In terms of financial issues, I was wondering, there's been some national coverage about misuse of powers from lasting powers of attorney, and I wonder if that's recognised as a problem. Do we have any sort of measures as to what's happening in Kingston?
I'd have to get data from the borough about that. I mean, that does crop up when they've been given power of attorney for a parent or a relative, and they're misusing that power. But I don't know the absolute figures at the moment.
Iona.
I might be able to help with that. So it's one of the things we look at our regular adult safeguarding and children safeguarding, but particularly on the adult side for a power of attorney. And our new appointed safeguarding lead in adult social care is doing sort of deep dives on that. But again, it is an increasing trend. Yeah. So it's something we're aware of and doing some benchmarking and case work around. Just to pick up on work with the police, so we do work with the Safer Kingston Partnership around scams in particular. They've done some very focused work in other boroughs in South West London, so again we're thinking of doing that in Kingston, but absolutely we'd be interested in taking up the offer around loops in GP surgeries. If we can take that forward, I think
we should link up Iona, because we've got a great guy who's from the police who's done a lot of the work in Richmond.
Okay, fab. Thanks.
Thank you.
Okay. Any other comments from board members? No. Rob.
One of the places I'm the local neighbourhood watch representative, so if you send us that video.
Yeah, definitely. Yeah, it's really, really useful. You wouldn't believe some of the scams that happen.
If you've got 100 jams,
yeah.
150 Catholic converts have been nicked just recently, so beware of jams. And the other thing, it's very interesting, you talk about dentistry. I went to the health and wellbeing and we had a presentation by the dentistry side, and it's one of the services that's still being run centrally in London, isn't it? It's not come down to a CCG or so. Maybe it's time to look at maybe bringing dentistry down to a CCG level and even a primary care level. And when we get the because I think that's what's happened is primary care coming down to CCG level would be excellent. So maybe dentistry is one of the things should come down to primary care level.
Yeah, I think dentistry and pharmacy are the two ones which are still held centrally.
Yeah. It was quite noticeable about the presentation we had that it's probably suffering because they were saying that the feedback and that NHS dentist is very poor, and maybe bring them down locally so they work more closely with the CCG might be the answer.
Yeah, unfortunately, that's not within our gift. We have to wait until NHS England. Sorry, Iona.
I think to follow up the point on homelessness, so we do sort of homelessness awareness events several times through the year. And actually, when we did the sort of deep dive around dentistry, we found we had a higher uptake. I think it was in the 60% that we have for our adult population generally in Kingston. So whilst it's still not, the sort of level we'd want to see, at that stage, it wasn't as poor as it was for access for perhaps regular adults in Kingston. So it doesn't mean we should ignore it, but I think perhaps having more needs assessment around dental access would be worth looking at.
Just a quick, they did mention that they go into school and this sort of thing, but I'd actually double check that and nursery school and that sort of thing, and they go into the schools as much as they say they do.
If I can qualify, yes, they don't go into every school. We go into schools of highest deprivation, and it would be our health visitors that are doing the work with nurseries rather than this specialist team.
Great, thank you. So, unless there are any other questions, thank you very much, Pete. Oh, sorry.
Just one final point, just to say, of course, the community reference group is active at Health Watch Kingston. We're seeing sort of greater footfall come through the door on this, and we're looking also at developing that to encompass the Making Safeguarding Personal agenda, working through Graham Snelling, who's our safeguarding lead at ward level at Trust. And around the homelessness point, we've just completed a final draft of a report of discharge from Kingston Hospital, whereas this particular piece of data didn't come out of the research that we actually undertook. We had heard alongside this research being done that there were some issues about sort of discharge of homelessness, people suffering from homelessness, dealing with homelessness, being discharged back into the community and where that kind of person then goes once they're discharged from hospital.
Thank you very much. Thanks. So, Peter, thank you very much. So, Fergus, we've come to the looked after children.
Thank you, Peter. And yes, so this is my hat trick of safeguarding papers today. So welcome, Vicky, who is our designated nurse for children looked after. And I won't say any more than that, other than let's hear about your annual report, please.
Is this on? That's it. Thank you very much. Good afternoon, everybody. My name's Vicky Fraser. I'm designated nurse for children looked after in Kingston and Richmond. I came into post in Kingston in July of 2018. I work very closely with Sandy Kenyon, who's a designated doctor for children looked after in Kingston. Sandy gives her apologies today. Unfortunately, she's on annual leave, but she would have liked to have attended. The reason for the report is to just assure you that the statutory responsibilities of the CCG are being met in regard to assessment and treatment of looked after children. When we're thinking about looked after children, we're specifically thinking about their developmental and mental health needs, which are a recognised area where they have a lot of unmet need. So what I can tell you from my report is that in 2018-19 there are 129 looked after children in Kingston, but just want to draw your attention to the fact this isn't a static number, and we have some flux. We have children becoming looked after and children also going home. So if a child's looked after, they don't always stay looked after. They often return home to their families. And we'd probably see in Kingston around 50 new children becoming looked after, and we're responsible for initial and review health assessments of these children. So again, when we're thinking about the numbers, we have lower than the national number for looked after children. I don't have a figure for Kingston, but again, our statistical neighbour is Richmond, and there are 20 per 10,000 children looked after in Richmond. It's 55 per 10,000 in London and 60 per 10,000 in the UK. So we have a small number, but I think the impact on health services can be significant for these children. The main reason for that really is that 55% of these children will have a special educational need, compared to 15% of the whole population, whole child population, and of those 26.5% will have an EHCP, and that's compared to just 2.9% of the population as a whole. So really significant need, mainly around social, emotional and mental health problems, and that's the biggest need, with about 38% of EHCPs for those reasons. So we have quite a high number of 16 to 18-year-olds in Kingston, so this 40% of our looked after children population compared to 23% nationally. And unaccompanied asylum-seeking children account for 22% of the population compared to just 6% nationally. So they have a really big impact on the services being provided locally. With the Children and Social Work Act in 2017, it gave extra responsibilities around care leavers up until the age of 25. So what we have to be mindful of is for the local authority, for AFC, they have 250 children who are care leavers and considered care leavers in their service. Now that's across both localities. They don't differentiate at that stage, but there's a huge need. And as going back to what Pete was saying, often we see young people who are reaching adulthood, they leave children's services and move into adult services, and it can often sort of facilitate a time of crisis and difficulty for that young person, and that's something we see quite often, and it's a conversation that we've started to have around how we can best support this particular group. There have been some challenges for performance, and these have been ongoing for some time. We've now taken an approach where we have escalated it within the CCG and also the corporate parenting panel, and there's been a robust response to that, and we've got a solid action plan in place. What we can see for quarter two is that there is an improving picture, but we're going to need a commitment from the local authority to see that continuing on a long-term basis and really embed it in practice. One other thing that's been a challenge for our medical advisor is the development of a regional adoption agency across South London. So Adopt South London, again, it's just working on an economy of scale, because if we're just working locally, we have such a small number of children who are in adoptive placements. We don't have access to the adopters or the expertise. But unfortunately, the medical advisor arrangements weren't considered in the planning and until fairly late on in the process. So we're in a situation where medical advisors are currently not represented on the adoption panel, but the arrangements for that are being put in place now to work out the legalities of it and who is responsible for the work that's being done and any recommendations that are being made. So, for instance, we often hear of adoption breakdowns with children, young people reaching adolescence. Things can become very turbulent and a lot of adopters can't cope, and some will seek redress. So it's just about being absolutely clear about who's responsible for that. Another thing that can be a challenge for us is consent for health assessments in Section 20 arrangements, which is a voluntary arrangement where parents retain parental responsibility. One way that we've worked collaboratively with the local authority to resolve the issue of obtaining consent is to create a joint form, and that has been that's been viewed by various legal representatives of our providers, and we are close to getting that into use once it's passed through the relevant governance. So we're hoping for that to be in use by October, and that will have a positive impact on timeliness and children being seen and their needs understood. The other thing, we've got a majority of our children are in foster placements, but we have some who are in residential settings, some who are in custody, and a lot of children are placed at distance from their home, and there's a big effort to bring children back into local settings. And there's several in Kingston, so we've got Greenleys, and a specialist mental health provision in the borough as well, which is great because then oversight of their needs is better addressed. It means that they can be closer to family, but sometimes there is an element of risk with that because there's children at risk of sexual and criminal exploitation. So really thinking about the contextual safeguarding issues there, and that's something that we're going to be thinking about, Sandy and I together. So staffing in Kingston is stable. Sandy's been in post for a long time, and I'm sure many of you have met her before. We have a medical advisor who is in post and has a particular interest in unaccompanied young people and works really well with that group. There's been ongoing audit to identify what's happening locally for children, and that's something we're looking to develop and also improve the summary reports that are provided for foster carers and GPs. Significantly, we've had investment from the CCG for a named nurse, and that's a very senior Band A operational post within the providers, and a lot of work has been done around a service specification so that the named nurse can work across both boroughs and provide that day-to-day operational leadership and really support service development. We're really keen to hear the voice of children in care, and we've done a project with the Children in Care Council. It was an AFC Children in Care Council, and we recruited several young people to take part in a programme where they had some mental health professionals come and talk to them about different disorders, and then we went on to complete a qualification which enabled them to become peer mentors. Sadly, we had only, very minimal representation from Kingston, and that young person actually dropped out, which was a great shame. On reflection, it's part of a larger issue with sort of logistically children being able to get to Twickenham where the meetings was held. So looking forward, the Children in Care Council will now be separate, so you have separate for Richmond and Kingston, and we would look to develop a project that they could access more locally. What else to say? We've got lots of aspirations for the service. Sandy and I have started to work really closely together to align and standardise across both areas and develop a data set that is meaningful to both areas. We've got lots of plans for audit and developing mental health assessment for children and young people when they become looked after, and we're working closely with the AFC Emotional Wellbeing Service to support that. And what else can I say? Oh, the final thing is that we are trying to develop a digital solution for care leaver summary. It's currently paper-based, and a lot of young people don't want a piece of paper. So we've devised a quick fix with the local authority that's going to be up and running fairly soon, pending their governance procedures, and then looking to branch out and do something a little bit wider across the piece.
That's great. Thank you, Vicky. So you wanted to add anything?
Thanks, Vicky. Yeah, I just wanted to mention, Vicky mentioned already about the Youth Health Champion model. That was work that Vicky was doing in her own time. And I'm really pleased to say that all of the children, whether they be from Kingston or Richmond, who participated in that, all passed and got their additional qualifications. But also, it's been such a success that the Royal Society of Public Health want to review it as a possible case study for them going forward. So I wanted to particularly just draw the governing body's attention to the outstanding work that Vicky does for children looked after. They're a particularly vulnerable group they're very invisible within society, and I'm really pleased that the work that we've been doing across Kingston and Richmond to lift their profile and their focus has been led absolutely by Vicky. So thank you.
Thank you. Any comments or questions from board members? Jim.
Hi. I think it's a fabulous report. It's kind of interesting and sobering at the same time. Children placed out of borough, it's a pretty high proportion for both Kingston and Richmond. How does that compare to other boroughs, both within London and out of London?
I think it's a challenge that's faced by most local authorities. I don't have any figures to hand. That's something that we could look at. But the main thrust is actually we want to bring these children much closer to home for many, many reasons. So in terms of accessing their health services, having a relationship with people locally, being able to be near their family and friends, to stay in the same school. Particularly children with disabilities tend to be placed at distance because the specialist provision is not available locally. So, for instance, children with autistic spectrum disorders, where they're, non-verbal and require 24-hour care, they're often, fairly far-flung. And children who have been victims of exploitation, often for their own safety, have to be placed at distance.
And obviously, one of the things I noticed is commissioning health assessments becomes infinitely more complicated because you're commissioning a third-party provider outside. We can't have children in every borough in England being placed in a different one, otherwise it's just a circular kind of transition of children, isn't it? There must be some way of stopping that.
I think there is a shift required in thinking, and I think Vicky's quite right. There are some circumstances where a protective strategy is about distance from the original location, but that should be the only time somebody is placed out of area, and we should be recognising that there's a commissioning requirement or a service delivery requirement to support the child locally. And I think historically it might have been more cost effective, if I'm brutal, to say that some of these things could be outsourced or done more cheaply in that way. It wasn't terribly child-centric, but I think many areas are now recognising that we need to build the services locally and invest in the services locally, because as we've said, it manifests itself in more and more problems the further and further away that children are. And it does make it very difficult. We've touched on the challenges around the timeliness of initial health assessments and then the annual reviews. No matter where we place the child, we retain responsibility for them as a local authority and as a CCG, no matter how far away they are still our children. So keeping them closer is absolutely the right strategy, unless it's a protective factor for that individual.
So I think absolutely it's recognising the joint approach we're taking between both the council and the CCG and looking at building resources. So we have a new school that's going to be built for young people with autistic spectrum disorder. It's not something we've had huge capacity for in the borough, so it's kind of having that catch up, having the facilities and then for the staff to then have children closer to home. But it's a bit of a long-term plan. You know, actually putting children further away from home, as we've heard, is not good for them for all sorts of reasons. And often it's private providers that are incredibly expensive to the system too, and when the pot's only so deep, it means that you can provide less provision to other children that may be also in need. So I think it's taking this long-term approach, and I think the joint work that we're doing now is certainly starting to tackle some of those very difficult issues.
Okay, thank you. Any other comments or questions from board members? Ron.
Just a comment really. Hopefully Chesington Moor Lane School is going to be a home for a special school in 2022 for students and children, so it is coming, so I'm really pleased to see it.
Thank you, Vicky. Thank you very much for a really good report. Okay, thank you. So can we move on to moving forward together?
So I'm going to be quite brief because we are going to have an opportunity later on this evening to have a fuller discussion on this. So what we're looking for in this section is to agree that we need to have a committee in common in September and the membership of that. So just to explain some of the background, we agreed in April this year as a governing body and the other governing bodies across South West London that we would move towards a merger of the 6 CCGs into a South West London CCG. This is a decision that is for the membership, not for the governing body. This is so we are currently in the process of engaging with the membership on this. And we have to also work to a national timetable to get the application into the regulators by the end of September. We recognise that it's been raised with us through the LMCs and through some of our members that the timescale is short and that the members would like some additional time to look at the documentation and to have a chance to work through that. So we have agreed with the LMCs and with the regulators that we can submit our application at the end of September and withdraw it if we don't get a yes vote, which will take place in October. That's the current position. In order for us to submit the application, we would like to have a committee in common at the end of September. It says the 19th in here. It's actually going to be on the 26th of September from 4 till 6, so that we can just confirm that we wish the application documentation to be submitted. And so what we're asking for is permission to have that committee in common and also for the membership from the Kingston governing body. There will be more time for members and others to look at the documentation and to be able to feed back on that, and that wasn't the intention of this part today. The 3 members should be GP, clinical lead, executive lead and lay member, and currently I believe the chair is available to come from the clinical perspective. We will make one of the executives, so it's really lay member representation, I think, from Kingston for the CIC and confirmation that people are happy for the CIC to take place.
I didn't know if proceeding date, but I can do that.
You can do that date. Okay. So, so the question for the governing body, are we happy to have a committee in common on the 26th of September? And for those representatives to be myself, David, and one of the other exec teams, which I presume will be Tonya. It'll be one of us. Okay.
We work it out between us who's there.
Is that okay? Are we quite happy to proceed with that? We'll have further discussions in part 2 this afternoon. Yeah? Okay. Thank you very much. So coming up to policies approved, there are 4 policies there that we've got in our document pack. The first is around Kingston and Richmond contract policy. The second is around South West London change management policy, South West London flexible working policy, and Kingston and Richmond children's safeguarding policy. So we've gone ahead and those have been approved. Are we quite happy to ratify with that? Yeah. Okay. We've got summarised minutes of the South West London Audit Committees in common for people to note. And also we've got the reference document, which is a glossary of terms at the back of the pack. So the date of our next meeting is Tuesday the 5th of November. It'll be here between 3 and 5. Do we have any other questions from members of the public, Rob? No? Okay, so if I can bring this part of the meeting to a close, can I ask that we just have a 5-minute comfort break? Is that okay? And then if we can head into the room just through there for our part 2. So thank you.